Joining us for today's webinar, From Data to Decisions, Using Clinical Intelligence to Improve Care Quality. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used today to log in to access the recording later. If at any time you have any issues with audio or visuals, please just try to refresh your browser. You can also submit any technical questions into the Q&A box. We're always here to help. With that, I'm pleased to introduce today's speakers. Dr. Michael Poku, Chief Clinical Officer at Equality Health. Dr. Michael Poku is a healthcare executive with expertise in clinical leadership, medical informatics, and value-based care. He has held leadership roles at Oak Street Health, Next Health Technologies, and Signify Health. A Johns Hopkins trained physician, he holds an MD from Vanderbilt and an MBA from Harvard. And Anthony Polizzi, Solution Architect at Reveleer. Anthony Polizzi is specializing in HEDIS and MA risk. He leads data acquisition and interoperability strategies, ensuring patient and provider-centric solutions. With experience in genomics, pharmacogenomics, and genetic cancers, Anthony drives innovation and addresses data gaps. His focus on provider sales enhances healthcare quality and reduces administrative burdens. Anthony is currently pursuing an MPH at Weill Medical School and an MBA at Cornell Johnson Graduate School of Management. Thank you, Dr. Poku and Anthony, for being here today, and I'll now turn the floor over to Dr. Poku to get us started.
And thank you so much, and thank you all for being with us. Happy to engage with this illustrious group today, and wanted to dive right in here. Michael Poku, Chief Clinical Officer for Equality Health. Equality Health, we are, I like to say, unabashedly Medicaid focused. We're a value-based care enabler. So we work with thousands of mainly primary care providers and over 700,000 individuals in diverse communities with a focus on improving whole person care outcomes for those diverse communities that are largely and disproportionately and historically disinvested communities. So we work with managed care plans, we work with patients, members, beneficiaries themselves, the primary care and specialty care providers, and then a whole slew of other stakeholders in the community, in addition to a whole host of folks driving non-medical drivers of health. So we have a strong community-based organizations focus to really connect the dots on a true biopsychosocial care model. So healthy outcomes, really focusing on relationships in the use of data and technology to really enable better care and promote healthier lives across the communities that we serve.
Thank you very much, Dr. Poku, and I'm very excited to be alongside you to take the team and these attendees along this journey. Reveleer, we have 15 years of experience, and we leverage AI to power value-based care by delivering insights and automation that drive efficiency for healthcare organizations. And that could be anywhere from a payer all the way to a provider and anyone in between. So think of those Equality Healths who sit between there to aid on both ends of the spectrum. Reveleer empowers healthcare organizations with advanced clinical intelligence, streamlined member management, data-driven quality improvement, and optimized risk outcomes, whether it be prospective or retrospective. And that's all housed within one platform. Our success and growth have resulted in our ability to touch over 66 million lives. Last year, we've ran through our engines over 1.1 billion pages of clinical information, in addition to other structured sources. We are proud to have served over 70 organizations while maintaining 70% retention. All this to say is, we've been in this industry, we are here for the long haul, and we are enjoying where this is going, keeping compliance at the forefront of our mindset, but understanding how value-based care will grow over and over. So with that, I want to talk to you about what we will probably learn today. So from a very high level, how clinical intelligence supports value-based care initiatives, the intersection between data-driven decisions, quality improvement, and risk adjustment, and the role of data that is used to improve patient outcomes by reducing unnecessary burdens. With that said, I understand everybody has a very busy schedule, and we're very thankful for you to attend today. And if you have any questions, obviously you can use the chat, but everybody will remain muted. And don't worry about taking notes. You will get a copy of the presentation, and this is being recorded. So from a very high level, if we think of the intersection between value-based care and data, we have to all understand that clinical documentation is the backbone of value-based care. And so as we think of value-based care, it's a chassis. So what arrangement it takes on from that is very unique, but at the heart of it, the same chassis exists. There's risk, there is someone carrying the risk, as well as the administrative burden that comes through that to understand the compliance, right? The data, as well as the clinical documentation, is the checks and balance of the program itself. And so what we see is that there's a very large onus of, administrative burdens. So truly understanding that at the end of the day, there's a lot of clinical information as well as structured information as claims information. But what that means is there's fragmentation, there's difficulty in centralizing that, harmonizing that information, and doing things with it. So understanding that, yes, fee-for-service has that same onus of burden, but value-based care, healthcare takes it a step further because it's truly the source of truth when we think of how these reimbursement models work, but then also the patient care outcomes. So really driving toward that patient-centric mindset, but using what we have and what we don't have, right? I think it's important that we talk from both sides of the spectrum today of where there are data blind spots and what that can do, but also we have all of this information. And now how do we look through a minimalist mindset to drive efficiency, but support providers, just like Dr. Poku, at the point of care, but then their care teams and then their administrative teams doing all of the activities that go with that. So with that saying, we've seen, hospitals with robust data analytics, as well as AI engines, truly understand that you can have better care quality under a value-based care arrangement if you're utilizing certain tools and functions to create those outcomes. Anything you'd like to add there, Dr. Poku?
No, I mean, I think it's just right, and I would highlight the data is doubling at such a dizzying pace, and increasingly with value-based care, we recognize the importance of non-medical drivers of health and the need to truly catalyze and push a whole person care model where we're thinking more than just about the medication somebody's on, but everything else that's impacting and influencing their health and human services journey. It becomes just critically important and imperative to not only grab as much of the data as possible that can be used to tie up that journey, to create a care plan, to be able to execute along that path, but also to process that data in a way that converts that data to those actionable insights and that wisdom and intelligence needed to be able to really drive whole person care value. So can't overstate the importance of really connecting those dots enough.
Yeah, and I think the broom here in the middle is very important because cleaning this information is the hardest part, right? Because if we don't have the right information in, we're not going to get the right information out, and then what that leads to. And so with all of this information, as we lead in, right, we want to understand what clinical intelligence is and how it's used within your day-to-day life, right, seeing patients, or how you're pushing this information to your teams.
Yeah, and to carry that theme of the broom and the need to connect the dots again, the amount of data, it's doubling and it's tripling at a very dizzying pace. But the need to, again, to Anthony's really salient point, not only understand what's out there and understand what you have and don't have, but to also understand how to thread it, to make a consistent message and theme, to convert it into that clinical intelligence, so that you're not just sitting on more data for data's sake. And I think that's one of the critical pitfalls that we've seen a lot of organizations take, where they understand that there's a wide corpus of data out there and they try to grab as much of the data as possible, but they don't have an intelligent processing layer to help create that longitudinal narrative to be able to do those things in bold, right? Because the aim here is to really understand and identify gaps in care, to improve those patient outcomes, and to identify risk factors that are driving unnecessary emergency department visits, that are driving unnecessary hospitalizations, to be able to address that, to take that unnecessary cost out of the healthcare system, to truly bend that cost curve. So being able to really do this in a way that recognizes individuals as people is a critical factor, right? So we talk about population health, and many organizations have, I would say, descriptive data that demonstrates the health and or relative burden of illness for populations, but really driving that into those enhancements that drive next best action at the individual tailored level is where many organizations sort of have a gap. So it's all about understanding what the population looks like, being able to dissect and stratify that population based off of factors that matter, to be able to drive those next best outcomes, to be able to help, as that last bullet demonstrates, what is the overall risk of the population. How do I think about driving care for that population in a way that is disciplined, in a way that is financially sustainable, in a way that's person-centered? And then pursuant to that second bullet, how do we always do this with a lens of quality improvement and iterative improvement on those outcomes, with a view on the processes and one's native workflow, to be able to really drive those outcomes ultimately that we all want, that's person-centered, that is done in a way that minimizes that abrasion for your patient, for your client, for your particular member. So critical that we sort of nail this, in that, again, extremely challenging to do without a clinical data partner, without that chassis to be able to convert and grab that data, to be able to help teams and really arm health and human services teams to do the work that we all came into healthcare to do much more efficiently and effectively.
Yeah, I mean, all of that resonates. And I think we really need to understand that not every population is like the one to the right of it. So the uniqueness of a given geography could be street by street. It could be zip code by zip code. It could be county by county. And truly understanding the nuance factors to that in your approach to outreach, right? Speaking their language. And it's not, their spoken language, but just understanding the nuance of what is happening in, that geographic territory. And then how you take that approach to care coordination gives it also that aided human touch, but you don't understand that without, the raw data in. And so as we think of, quality improvement from a mindset of a underserved Medicaid population, right? We have to understand immunizations. And so as we think of CIS measure and really honing in on the nuance for the CIS measure, given a certain geography, right? These are probably struggles you deal with, given some of your markets. And how do we aid, or how do we campaign in a way that creates that encompassing or that unified front to create better health outcomes, is likely driven with, other information that most people don't realize is even being transmitted. Jumping ahead, as we think of where there are challenges is we talk about value-based healthcare. It has been around a while, but what at the heart we still are seeing, difficulties on implementing different AIs and automations in these mindsets, because we have to understand that not everyone is on the same continuum. It is definitely a moving target when we think of early adopters versus people who have been in the space, 10 years, but then people who have been in the space 5 years. They've had very different experiences in value-based care. And so when we think of some providers in certain areas, it's my patients, my data. And that for us is very difficult, because if we can't get access to this information and transmit it back to the point of care or do something with it, we are continuing down the path of siloing healthcare in America. And I know in 1996, when they came out with, we're going to be fully interoperable by 2000, and as I stand before you in 2025 in the messy middle of TEFCA, right? It's still a real problem. And the acknowledgement of that is very important. So meeting people where they are has been a pathway, or having the open conversations of, well, we do know that you have this information, right? But how is that going to help the doctor who's treating them down the street? And how do we get that information there? We also know that still to this day, we function in a fragmented language of healthcare transmission. And so when I say that, there are thousands of ways to send a record, get a portion of a record, get a claims function of that information. And I'd be remiss to say, everyone has had this solved, but it's not. We're seeing fire. We're seeing, better technology, but we're also having to look in the eyes of people who are just not technically mature to be able to transmit that information. And so whether that looks like a CCDA feed off the back end of a small EMR that's home built that we can likely, pinpoint or get something, some data is better than nothing. An interesting, function when US Digital Data Services rolled out data at the point of care, what we saw was providers who are treating patients who likely they were newly attributed patients. And I'm sure most people on today's webinar struggle with this. How do we get information on a patient that we've never seen before? Yeah. And how are we expect to know what their, burden or risk burden or anything on them looks like? And so when data at the point of care rolled out DPC claims, which was a bulk fire option for them to be able to pull historical fee-for-service Medicare claims data, it gave them something. It was a step in the right direction, and that pilot started in 2018 and it's still not off the ground. And what we see is some data is better than nothing, and providers will, continue to say, okay, well, now that I have this, well, that begs the question of, okay, now I've seen that this person via this claim went to this doctor down the street. So that does unlock a way to say, okay, well, maybe I can go retrieve that record from that provider to see really what happened at that encounter, because we're not getting encounter data. We're not getting E37s. We're not getting all of the robustness that a provider would want to make clinically based decisions, given it's the first time interacting with that provider. We also have a broad swath of providers in today's market of the adoption of, really using AI, using other data sources at their point of care, right? We still have people on paper records.
Yep.
And all this to say we have to meet providers where they're at to be able to move the needle to truly understand what we're doing and how we're doing that. And I mean, I'm sure Dr. Boca, you can layer in there around the same and how you engage with your providers.
Yeah, Anthony, at Equality, we work from everywhere from, single provider practices all the way from large academic medical centers and in large FQHCs. So certainly, to borrow and turn the phrase, meeting providers where they are is one that resonates with us quite deeply. So, the journey here as we, experience this wave together of all manner of enhanced data science techniques, whether it's generative AI, LLM, et cetera. It's the ability to develop configurable solutions to understand where a provider, where a health system, where a hospital, where a practice is in their journey, in their maturation curve as it relates to clinical intelligence solutions and in really utilizing and implementing the same. And you need to be able to reach out and have those solutions for that provider who's just now transitioning onto an EHR for the first time, in addition to that provider that's got the latest and greatest LLM model and they're sort of running it through structured and non-structured data. And pointing that in those solutions, again, always towards that person-centered piece of how do we arm our care teams? How do we arm folks that are outpatient-facing, client-facing, to be able to, again, really push those tailored solutions in a way that's culturally sensitive, to the point that you made earlier, Anthony, to a way that acknowledges and recognizes various seemingly disparate pieces of data as it relates to socioeconomic status, as it relates to census data, as it relates to medication adherence, and really put out that next best action to help those frontline teams, again, understand on a better frame who those individuals are that they're taking care of. And then a big one, particularly in the Medicaid space, is often who you're not taking care of, right? So who's unengaged, who have you not seen, but it's got your practice's name on the back of your insurance card, and how do you think about that environment in terms of who to call next, and when to bring them in, to that last point there on the slide of really understanding what the risk profile is, and at least the way we like to talk about it, how do you dose the right levels of primary care? How do you dose the right levels of social care? And how do you think about who needs what? And how are you delivering that through what medium and channel?
Thank you. And it's impactful, especially probably when you're eye to eye with a colleague of yours explaining this, especially when they're new to value-based care, of being in fee-for-service for 20 plus, 30 plus years, of a patient's coming in and I bill a claim. Yes, you do. But now how do we take that the step further and say, all right, you're really not at risk, but you're really going to be able to maximize the outcome of this patient's life. And I think that's probably an easier conversation to have colleague to colleague, just because if we can have that same language of communication there, they'll definitely probably open their minds more to be more adaptable to technology and whatever we're trying to put forward.
I think it's one of the thrilling things about this transition to value-based care and whole person care that we were continuing to accelerate. It's the fact that this is where we need to go, right, from a societal perspective. And we need the technology tools, we need the data science solutions to be able to catalyze and push that. So the nice thing is that this is all very intuitive for, depending on the stakeholder, for whomever you are in the landscape, whether you're a community-based organization, whether you're a hospital, whether you're a specialty provider, whether you're a primary care provider, driving better outcomes at a lower cost point, again, is a very intuitive thing. So the need to sell value-based care, I think, is sort of going to the wayside. Now it becomes, how do we actually mechanically execute on value-based care in a manner that makes sense? And again, depending on who you are, what are the revenue models, the economic models, such that we can do that sustainably, and hopefully, at least from a futurist perspective, utilize that data science and the technological tools to advance more of this care and these outcomes to more population. So not about sort of shrinking who we're doing and doing a better job too, which I think there's lots of historical models that have largely focused on that. But the clinical science in clinical intelligence solutions that folks like Reveleer and others have, it's increasingly allowing more care to be provided that's more evidence-based, that's more clinically intuitive, that embraces cultural humility, and that allows one entity, one person to reach out and touch more than they were able to do last year, than they were able to do yesterday. And I think that feels really good. Again, the big story now is just how do we connect the dots and transition folks depending on where they are at in that maturation phase that you articulated, Anthony.
You know, and I echo that, but right, I think what you just said, right, how do we make people more efficient to touch more population? And maybe it's not having to touch every single record.
That's right.
I think that is a true beacon of AI. So as we think of truly understanding patients and the clinical burden, right, we hunt and peck for records all day long. But now that we have that information, are we truly looking at it for the right reasons? Is there clinical validity behind that? Is it a discharge summary that has, you know, blanketed assessment on how to take a bath that we're sending a person to look through to truly understand if this patient, you know, adheres to the DFS measure or, right,
Yep.
had a true screening at that given point in time? And I think that is the true value driver behind the technology.
Yeah,
So
100% agree. It's about, again, arming care teams, arming teams more generally to do the great work that they're already doing in a much more efficient manner, putting them on a glide path and putting them in hyperdrive, taking out unnecessary manual processes, taking out manual processes that are readily machine readable and lend itself already to some of these more advanced data science techniques so that, you know, folks like myself and physicians and other people, we can focus our time on higher priority activities and focus our time not necessarily on the administrative tasks, but taking good care of patients. And I think that's, again, the promise of some of these advanced clinical data science solutions.
So we hit on many of these different things, but if we think about this in a workflow, or how do we convert information from raw data to actionable insights, right? That's what I think we're going to get into here in the meat and potatoes. So as we think of data collection, everything within value-based care and most healthcare settings starts with data. So whether it be records, whether it be claims information, whether it be HIE information, think of lab feeds, pharma feeds. I mean, I can go on and on about all of the fragmented sources of information that have to be compiled to one place. And so if we can centralize all of these fragmented sources, especially for people like Equality Health, right? Equality Health has to have 72 different ways to transmit information because of all of the different populations that they're serving. So think of HIE feeds given 7 states or given multiple markets that, right, Texas is one of their states that has 3 HIEs. So thinking of that, right, how do we centralize that into a collection to keep that repository robust enough to do something with it? So maintaining up-to-date information on patients is very important. Understanding the cadence of where patients are and what they're doing is also important. So ADT feeds, appointment feeds, those act as that clinical trigger for us to then pull in information to then centralize it. So data hygiene and integration is very important. So whether it be building an API that's native, you know, to Epic to pull information because we know we have 7,200 members or patients right there, that's probably our biggest squeeze to get as much information out to then compile it or to complement it with other data feeds. So as we think of looking at patients on a holistic level, there are a plethora of sources of information that you'd want in one given spot. And that's our goal, to centralize all of that information. So whether it be SDOH information, whether it be structured information that you're getting from your claims information, or in Dr. Poku's, right, the MAX files for Medicare, Medicaid, or your MAO 004s or your CCLFs, right? Yep. All of that robust information that then has to be synthesized or harmonized in some way. So as we think of cleaning information, I mean, we could stand here and talk about all of the different ways that you have to understand a patient identifier across that continuum. And how do you make a decision tree to make that, you know, universal patient ID so that we know that via this LabCorp file, it's coming in via, you know, let's say an MRN, but then we have another EMR ID, and creating, you know, this robust repository of 15 IDs that match or can be traced across that continuum so that we know it's right patient, right record, or right piece of clinical information so that we can take it to the next step. And the data analysis is truly, right, it's the meat of what we do. It's how do we look at it? It's a layer cake approach depending on what the data type is. So there's different confidences, different levels of information we can get. So thinking of that unstructured mindset, truly looking at PDF records, JSONs, HTMLs, getting information in that are wrapped XMLs and CCDAs, but unearthing those and creating that human readable view, even with structured data sources. So if we think of an HL7 feed, no doctor is going to be able to read an HL7 feed. We have to be able to put that into a way that can be viewed, that we're looking at this as a record, as a true lab value, or what was the diagnostic that was ordered at that visit, and then what were the results of that. So really creating that human readable format is first and foremost our important piece, because the goal is to pass that along the continuum. And so once we have that, then it's a layer cake approach, depending on the type of information you're looking at. Think of your unstructured information as things that people would read. So how do we layer in NLP and then our clinical heuristic engine to be able to churn out what we're looking for? So as we think of different functionalities that all affect care, we also have to acknowledge that there are all different lenses we have to look at this data through. So it could be a predictive lens, because we know patient Anthony is going to be seen by Dr. Poku tomorrow, and we want to make sure that everything that Dr. Poku is seeing is up to date, but is also actionable. So let's say Anthony's BMI is 36.5 and he has a comorbidity of this, right? We can triangulate that through our clinical mindset with the underlying information to say, okay, here, Dr. Poku, we think, or we infer, or we're querying you to say, this is what can be going on with Anthony. You likely want to see it at this 10-minute visit. But truly harmonizing it into that actionable insight is understanding what is happening at that encounter. So think of a 10-minute visit versus a 40-minute visit with a patient. How do we know, or what do we do to aid in that continuum? So understanding that time is very valuable, and likely we would only want to push via native integration to the point of care things that are the highest fidelity or the most simplistic approach at that visit. So a 10-minute visit might only have one insight on Anthony because it's a sick visit, but maybe we can also use that to understand other acuities that Anthony has. But knowing that Anthony's coming in next week for a 40-minute visit can open that aperture and say, okay, we have more time. Let's feed more information that is substantiated with clinical information, right? Whether it be, a diagnosis gap or a quality gap, because we know, oh, Anthony might need a colonoscopy, given that our payer has just told us they don't have anything within their claims or HEDIS engine that does that. So, okay, there's no record of it, but let's see. Does Anthony need this, right? We may be able to find that in the record ahead of that visit and have Anthony truly confirm what happened on, 5 years ago that he grabbed a colonoscopy or a fit test down the street, and then getting that sign off from that patient carries that on. And so all that to say is then there becomes the administrative process. So after I leave that office, it's how do we get the right information before that encounter leaves the door, so we know that our documentation is matching truly what happened at that visit, so that we're truly understanding the patient's risk profile is very, very important. And then it continues on that process. So it's definitely a cycle, just because now that we have the right record, now we have more claims information that helps substantiate what we've said as an actionable insight. So yes, we thought Anthony was morbidly obese, but now we're going to see that come out on a claim, and we're going to see that substantiated through HHS or CMS or whatever function that is coming through to say, okay, well, the provider accepted that, the provider actioned that, CMS then worked through that, they adjudicated that, and now we have the clinical documentation to truly substantiate what happened at that encounter. All right, now it is time for our first poll question. And I think this is definitely for us to get a grasp on how much information are you dealing with in your daily lives? So as we think of different data sources, we know that there's a plethora. And so I guess we're just trying to get a feel of how many are you trying to centralize and work through in current state. So I'll give you a few minutes. I believe the poll is launched. And we'll wait until we have about 70% acceptance.
Yeah, always interesting to see the volume of data that various entities are working through. So excited for this response here.
Still seeing some come in. And I think it's important to acknowledge. I think this is the clinical data conundrum that I've.
Absolutely. It's and again, the challenge here is that as we continue to embrace whole person care, as we continue to recognize the importance of social, political, environmental determinants of health, and reflect on that, the data, the pertinent data, begins to just spin out, and the cup runneth over in terms of the number of data points that would be overall pertinent for health and human services provider to be able to drive.
All right, we're cresting about halfway there. Give you another minute. I think it is important to see what
for sure
the field has.
Yeah.
All right. That's what we thought. And so, I mean, the audience is definitely comprised of different players along the continuum of healthcare. So health systems versus payers versus, SINs or IDNs or IPAs. But as we expected, more than, the majority of people are managing 6+ types of information or independent, functions of data in one place. And so I don't think anyone has that perfectly hacked out, but if we could think about that on a use case dependent, right? I think it's important to bring up, but if you can centralize that repository that we've worked very hard on creating this like central chart lake functionality of all of this information in a patient-centric mindset that's queryable, that's storable, indexable. I mean, it also aids in your use case. So think of, pulling a chart or having a chart on a patient existing, but being able to have multi-use case and have it in one place for multiple teams to interact with just by having, a searchable function that we don't have to depend on a nomenclature or go to a SharePoint or here's a repository down the street that handles quality versus here's the one that handles risk. And how do we unite that so that we know that when we're pulling information or going through that retrieval process, we're doing it for the right reasons to capture as much information as possible.
So, and Anthony, to your point, that virtuous cycle that you represented, it speaks to the challenge well in the one here in terms of how do we really think about the frontline teams? Because I think a lot of organizations inherently understand that they've got data deficit challenges and that there's data out there that's disparate, that's fragmented, that it's out there in the ecosystem that they don't have, that they would otherwise need to make good decisions and to empower their teams to make those good decisions. So what do most do? They go and figure out how to get as many of that, those data points and those data assets into their shop. But then what happens? What happens is then you park it, and you may even think to park it all under the same repository in an enterprise data warehouse and a data lake, et cetera. But then if you haven't done the good work around master member, master patient indexing that Anthony described, if you haven't done the good work around processing and understanding that, Mrs. Jones here is the same Mrs. Jones here, even though they're on different health plans, even though they're seeing different providers, even though that she used her middle initial in this one and a different sort of nomenclature and spelling on this one, you still can have this data fragmentation challenge. So really being able to do it and leverage it on that first point for real-time decision support, so that it's not somebody looking in arrears, or it's not, hey, I've got 200 pages of data that's all PDF that nobody's processed, that you clinician in 15 minutes I'm asking you to now be responsible for. You're not necessarily helping just to bring in more data if you do not have the inherent processing layer in the data science prowess to convert that into insights, right? To truly improve the workflow efficiency, so that you're not creating more noise and fragmentation. You're actually helping somebody to do better work more effectively, to reach out to more folks. Again, to that point, Anthony, that you made on your last slide, of really understanding the risk profile and understanding where homogeneous groups may arise, to drive those targeted care interventions to ultimately meet those quality metrics, patient-centered goals in individualized care plans.
And how we've really solved that is becoming native in the workflow, especially at the point of care. So having native relationships with EHRs, Epic, Athena, Cerner, right? Really working through that tree of how do we get this information in a consumable format to the provider? And so bundling it and packaging it up in a way that's consumable is very important where they're already documenting. So it's leading the horse to water and then allowing them to look at the water so they can drink it. So seeing it when you're in your assessment and plan has been our biggest benefit, or our biggest engagement technique, because then people aren't going to fragmented portals. Think of the days of having to go to the clearinghouse to look at things, the Availities, right, the Trizettos of the world, where everything from pairs was stored. So what we've done and what we continue to do is hone and sharpen the pencil of how do we get better at the point of care with those bi-directional relationships and build more and more EMR partners, because the goal is to get better premium channel content into the workflow so that they are up to date, right? There's claims lag. How do we get ahead of a HEDIS certified software that's only being refreshed by twice a year? So we can, sift through that information and say, all right, well, we think we've closed a gap. Here's where it is in the clinical information. Put it forth at the point of care so we know that we're not creating patient abrasion to pull that patient back in for, let's say, CBP, right? End of the year, we're in the fourth quarter, right? Most recent CBP, right? It wasn't coded right because we know there's a continuum of CPT and CPT2 of how providers document. But if we can get that value and send that as supplemental information that we're already getting out of that EMR, right? We're not pulling a patient in, we're not doing a home visit, but we're also closing that gap.
Yeah, no, I think it's incredibly well said, and the solutions that really understand and gets into this case study and get into the native workflow, I think it's paramount. It's another really big blind spot that I think organizations miss, where they understand that they don't have the data, they try to go find the data, but then if they don't understand, particularly for the clinical folks among us, how your clinical teams are doing work today in their native workflow, and you try to co-opt that in a way that does not first understand their native workflow before you push the behavior change, you are careening on a path towards danger and despair. So understanding how folks are doing work today and how do you promote it within that native workflow and system in a way that, again, pays heed to evidence-based care, that pays heed to the need to tailor things at the patient level is pretty critical. So the big challenge here on a case study, right, is, which again is not going to be uncommon for many folks in the audience and viewers here, really trying to address an issue that plagues many of us of high readmission rates in those missed opportunities and missed care gaps in the course of a transitions of care visit. One large impactful solution here, as we've been talking about, it's really honing in on the clinical intelligence and the data solutions, right? So being able to understand from a whole person care model who is at risk of readmitting, why they're at risk, what is their support system, what's their historical ability to maintain adherence to their medications, to their overall treatment plan, and why, and what does their risk look like a priori, and has that changed during the course of a hospital admission, or all things that we can readily answer today with the right clinical intelligence solutions and supports. So being able to understand that data, arm those individuals and those families, because often thinking about patients as their familial units in their support structure, and how do you give and deliver information and support in different manners to be able to really drive impact. And we've seen through nimble solutions, 15% readmission reduction, better patient outcomes through whole person care models that think about who needs what when, and delivering that through an omni-channel approach. That's in-home services, that's telephonic, that's making sure folks get into the PCP, but it starts with understanding who that individual is, what their support structure is, how do they like to be communicated, what was their past in historical barriers as it relates to non-medical drivers of health, and how do we think about that proactively during one's course of a transitions, which, as we all know, can be so perilous as it relates to any number of things that can fall through the cracks. Did they pick up the medications? Are they going to see a follow-up within 3 days, within 7 days? What happens with red flags and if other signs and symptoms happen, if there's a recrudescence? So the ability to package all that up with clinical data insights, arming that particular patient and the family, arming the clinical care teams to be able to drive differential impact and differential action at the front end based off of the data is a critical piece here.
Thank you, Dr. Poco. So as we think of the engine itself, or really how we've lived in this space for so long, so we started developing our AI about 7 years ago, and started with NLP. So as we think of the umbrella of AI, NLP does fall within there, and then that aiding into machine learning. So as I alluded to in the past, there's different lenses to look through for the different campaigns or the different functions that we are trying to, adapt to. So obviously a quality use case is going to have a totally different function than a, clinically intelligent pre-encounter NLP or process in that mindset. So think of understanding different diagnoses, documentation patterns, but what that also means by triangulating that with structured information. So marrying structured and unstructured data to say, okay, we have an A1C of this, but we've also found in a previously documented record on a patient that this patient's on metformin. So that was in a note, an unstructured section, right? That's very important to put that two together, depending on what that A1C is, to say, okay, this patient likely or might have diabetes. The same is held true for a PCP who didn't order a CT of a thoracic spine, but what came back on the impression was calcification on the aorta. This is stuff that's likely or sometimes missed depending on who is at the helm of that care team and when they're interacting with that. And so our goal here at Reveleer is to unify all of this information, to share that information in a way that is actionable when a patient is being seen. So that calcification on the aorta likely says that patient's going to have atherosclerosis, but that PCP who's seeing that patient likely doesn't know that they're seeing that patient because they're in for a sick visit, but that's very important information to know. And so all of that to say is that the way that we've built our system is to fight, algorithmic bias, to fight cognitive bias, to fight training bias. So as we think of training bias, right, there's bad information in, bad information out. So how do we get the most high fidelity, clean information in so that we can understand what we're looking at? And then think of the algorithmic bias, right? That's repeated errors. So our goal is always to be transparent. We always keep a human in the loop. So keep thinking of that as a person who is, looking through information before that information to validate that, but also that reinforced learning. So when we're at the point of care, we're able to understand the interactions of the provider to say, okay, the information we put forward is truly substantiated and then gets documented properly, knowing that the model has worked. So that reinforced learning mindset, allude to trust and transparency, but we also know that fairness and compliance are at the helm. So AI, right, governance is definitely something we talk about. And so the Coalition of Healthcare AI is definitely making strides for that. And we're going to see an uptick in the industry of more and more of that. And we're definitely cognizant of where that is because, compliance is definitely our forefront. Another very high level of how long has this been in the continuum, right? So we were an early adopter, but we were among other players in this space. And we really sharpened our pencils on understanding the different use cases that affect value-based care and value-based care trends so that we could get ahead of the curve of understanding, the AI bubble, right, that we're currently living in, I would like to say, but we've been there. So really understanding that the substantiation of what we've done and what we've built has been here for a while and has been truly tested, right? We've been in the space now 15 years, working with an AI for 9 now. So really understanding that other players in the space, but we are partners. And so partners like Equality Health definitely drive the product to its best ability. Another polling question. How is your current organization leveraging AI for clinical intelligence or for any type of, patient interaction? And why this is important to us is we're trying to drive the understanding that AI in current state is becoming more widely accepted in, aiding in that administrative tasks. So if we think of all that goes into preparing for a patient visit, right? I did see some comments in the chat around, visits and number of pages. A provider doesn't have the time to review a patient's whole, record in continuity. And we're very much of the mindset that the EMR that the provider is currently working in might not have everything stored in discrete fields. So there could be documents in the document section. There could be other information. Think of how Epic has Care Everywhere. So if you can centralize that and really hone and look at all of that information that is truly documentation on your patient in a way that allows, you to see a quick, brief excerpt of what is the most important pieces of that so that you're truly diagnosing and managing that patient in that current state to the best of your ability. As Dr. Poku has said, there is, great patient outcomes there. All right. Interesting. I definitely should talk to that 56.4%.
Yeah, lots of opportunity out there, it seems. So that's fantastic in terms of the upside potential to really impact patients and communities.
Yeah, and Dr. Poku, what would you say to someone who is, they have cold feet around using AI within their organizations or healthcare in general?
I think it's going to become table stakes. So getting one's feet wet. I would say the other thing that many organizations are using AI in certain areas, and you may not be aware. But it's something that again is going to become a component of all of our lives. It's become a component of all of our lives in many other respects and sectors. So we need to embrace it. We need to iterate on the technologies, and we need to, Anthony, to your point, always keep that human in the middle to make sure it's making that 1 + 1 = 3 in a synergistic manner.
Yeah, thank you. And with that, I mean, we do have, more information in these slides, but with the last 5 minutes, I think Dr. Poco and I would love to take some questions. So Rosie, if you could find some. I did see that there was a lot going on within the chat, so we'd love to cover some questions.
Yes, thank you, Dr. Poku and Anthony, for such a wonderful discussion today. We'll now start the Q&A, and for the sake of time, we do have a hard stop at noon, or at noon Central Time. So I just want to start with the first one that is noting the challenge of bringing together all of this robust data from the different sources. So it's asking, what are the biggest challenges in integrating clinical and claims data for a complete patient picture, and how can we address these challenges?
Yeah, and I think that's a great question. I'll take first swing, and I'll let you follow up, Dr. Poku. So I live in the world of fragmented data and trying to solve for that. And so how we have done it is truly unifying the two and understanding the source. So understanding claims information and giving claims information substantiation is very important. And how that can be done is by marrying it with unstructured data. So if you think of a claim that came through for a patient and we're seeing an ejection fracture of X, but we also want to know more about that and what happened at that visit to give that grievance so that we know that that patient, should be treated for CHF, right? We're able to marry the two. And so being able to streamline and create a viewable format that shows the credence and the, substantiation and the source information of where we're getting that information, it's very important. So understanding the discrete data that follows or the metadata that follows that unstructured source allows for us to say, okay, this was this visit, this day at this given time, because we've, reinforced that with a claim now. So you have double substantiation, which gives it more confidence.
Yeah, the confidence levels is, I think, increasingly important, Anthony, to your point. So it's about threading that narrative and making sure that, again, to Anthony's point, you can tie the structured and unstructured to create a clinically rational argument. And in Anthony's nice virtuous cycle there, at the bottom left-hand corner, he represented something that I think is extremely important in terms of the data hygiene piece. So it's that garbage in, garbage out, as we've all heard. So it's the ability to really, really understand what the data is and being able to reinforce the pieces so that if somebody fat-fingered an ICD-10 at 1.3 years ago, you may or may not want to chase that, right? So if it was a misdiagnosis of a benign skin condition, maybe not as important, particularly if you don't have the reinforcing points. But if it was an abnormal mammogram that was missed and not followed up, it may be something that you push. So hard to really get at that without some of the advanced tools, NLP and other things to really drive clinical insights and to be able to push things appropriately to clinicians and care team members that minimizes that noise.
Great, thank you so much for that. Yeah, our last question, an audience member is asking to elaborate a little bit more on one of the points Anthony discussed. So looking at how can healthcare organizations ensure that clinical intelligence insights are actionable for frontline care teams?
Dr. Poco, as you interact with
the first thing I would say to that, it's working with good partners, vendors in constructing the output such that it is clinically meaningful, right? So you don't want to have folks in the back office doing this or folks doing this from an ivory tower. You want to involve your frontline folks early on in this journey to understand what their pain points are, what the outputs, and how they're actually going to be using it in their day-to-day workflow. So studying the workflow and getting those folks out into those meetings on the discovery sessions, et cetera, on an early end. But I don't know, Anthony, if you've had anything to add to that.
No, I think that's a great call out, but it's also being able to be flexible. What we've found is being flexible, because we do know that every provider is different. And so there's different tolerances and different channels that we have to pull, or different levers within the tool itself when we're interacting at the point of care. So whether it be confidence thresholding, or whether it be us, tuning a unique rule for that provider, right? We want to be your partner, but we also know that there's idiosyncrasies within that as well. So being the best partner we can is definitely our strong suit. And so I do believe we are at time. I thank you, Dr. Poku, for taking the time with me to talk through this. And there are next steps. If anybody wants to reach out to learn more about Reveleer, or join our next webinar, we actually have one tomorrow around AI and clinical collaboration. There will be follow-up sent out.
Thank you
everyone.
so much. Thank you, Dr. Poku and Anthony, for an excellent presentation, as well as Reveleer for sponsoring today's webinar. We really appreciate it, and we thank you for joining us. So everyone, I hope you have a wonderful rest of your day.